diretora executiva do Consórcio Internacional de Universidades por Redução de Demanda de Drogas. Ela vai falar hoje aqui, durante 50 minutos, sobre prevenção e a universidade. Mas se vocês entrarem no site do Free Mind, em palestrantes, e dar lá mais, saiba, vocês vão ver o currículo dela, que é muito extenso, muito interessante, e ela desenvolveu aplicativos móveis para o uso de prevenção e tratamento, e a gente conversou um pouco aqui sobre uma possibilidade de fazer isso aqui para o Brasil. Então, convido para subir ao palco Dra Kimberly, uma salva de palmas para ela.
Thank you for coming and this evening and for my talk. It's late, I know you had a long day. Language has been something that I've been focused on a little bit today, so I want to, before I start my talk a little bit about language. I have spent the whole day listening so hard, and I keep forgetting to listen to the translator because I'm watching the speakers and I almost understand what they say by the way their face has an expression or by what the pictures are on the screen. And so I suspect that you will be feeling that way now, as I have felt all day. So I almost understand. But the funny thing about language is, even if we spoke the same language, we don't always understand each other. And one of the words that I think we use that means many different things to different people is the word prevention. So before I even talk about what I'm supposed to talk about, I want to talk about prevention and what that word means to me, so when I say it, you understand what I mean by that. Okay, see if this works. Did you do that or did I do that? Okay, so over here. Ah, okay, backwards, okay, got it, sorry. This is a model of prevention that is the most popular model in the United States. It was created by the Institute of Medicine in 1994. Have you seen this picture before? No? In this picture, in this model, prevention, I'm going to hurt somebody's eyes here. Prevention is the dark green, and it's called universal, targeted, and, no, I forgot the last word. Indicated, thank you. I can't see the slides either. And treatment is something separate from prevention in this model. So it's part of the continuum, but it's a separate thing. All right, let's see if I can make this work. This is going to be a much longer presentation than I thought if I can't make the technology work. More? That's the other way. Hard. Do it hard, he says. Okay, okay, that worked. This is just another way of portraying that same thing, where prevention, the different kinds of prevention are in this pyramid and then treatment is on the top. Have you seen this picture before? Yes, you've seen this one. So it's really just another way of portraying the same information that was on the other one. And these are very popular models of prevention, but when I say prevention, I want you to think about this model. My PhD is in public health, and so when I think about prevention, prevention means everything. And there's different levels or kinds of prevention. So there's primordial prevention, which means we're trying to reduce the risk factors. We're addressing risk factors, things that are underlying determinants of a condition. And primary prevention, we're addressing exposure. So primordial might be for preventing substance use, it might be addressing child abuse. And primary might be reducing access to alcohol by raising the drinking age or something like that. And then secondary prevention is screening or brief intervention, so something that tries to address the condition early on or shortly after it's begun to have symptoms. And tertiary prevention is what we call treatment. So if you're a treatment person, I want you to know that I actually think what you're doing is prevention. And if you're a prevention person, I want you to know that when I say prevention, I really am thinking about this whole world of all of the different layers, all of the different ways that we are preventing. So we are preventing use, we're preventing having the disease of addiction, or we're preventing death in some cases. That might be something that we're doing in tertiary that some people might call harm reduction. And so that's, when I say prevention, to me, that's what that word means. It kind of means everything that probably all of us do in some way fits into one of those prevention categories. So that's just for me to clarify to you my language in English, and I wish I could hear the translators and understand what they are saying to you, to know if it's actually meaning the same thing that I mean it to mean. There have been major achievements in reducing global drug use. We have research that has helped us know what works best. Now, we still have a long way to go. The research is not perfect, but we have 70 years of research in this field that tells us what works. But the problem is we don't mostly do what the research tells us. And so we live in this, the language I use for this is we live in this vicious cycle. We have this vicious cycle where drug use affects the person using, their family, the community they live in, the whole society. It crosses state boundaries, it crosses international boundaries. It affects all of us in this vicious cycle. So it's not just the use, it's the trafficking, it's how it affects government in terms of corruption, it's how it affects families in terms of violence. It affects everybody. So right now, in many cases, we have a vicious circle. And sometimes the things that we do don't help. They actually can hurt. And that's one of the problems I think that we have. Now, so I picked things that happen in the United States. Now, we in the United States have this habit of thinking we know better than everybody else. And we want to tell you all how to do things in your country. And well, here I am on the stage doing just that. But we don't do everything perfectly. And these are some things that actually do happen in the United States. And I know, so for example, detoxification without any follow-up treatment is actually the most common service that people get in the United States when they go seek drug treatment. And unfortunately, we still have things, not that common, but we still have things that I would call torture in the United States that are called treatment. So the cold showers, the hard labor kinds of things. That even happens in the United States. Now, not state-sanctioned treatment, but that still does happen in some places, and it's called treatment. Media campaigns with nothing else attached to them, no activity attached to the media campaign is probably the most popular prevention activity in the United States. And in media campaigns, and we have a course on it, media campaigns can be very effective, but not all by themselves. They have to be attached to a plan that has other kinds of interventions and activities. And scare tactics with at-risk populations. Now we know that if you try to scare kids that are at risk, you generally are enticing them to do whatever behavior you're trying to scare them away from. But that's a pretty common prevention tactic that is used in the United States and other countries. And what happens is when we use those things that don't work, and they don't work, then people think nothing works. And I know even in universities where I have worked, there has been a belief that you can't prevent substance use, you can't prevent substance use problems, because the kinds of things that they have seen used are these kinds of things that don't work. And so because of this, people don't know, people everywhere don't know, the general population, policymakers, educators, even some people that are doing prevention don't necessarily know what works and feel sort of as though maybe nothing does. Get closer. Oh, there we go. So we have this vicious cycle that we live in. And I have this dream. This is another picture from the Institute of Medicine. I think they have a great graphic artist. I wish I had that person working for me. The Institute of Medicine created this, and they talked about this in a learning health system. And I think it's a great visual, a great picture of what could be the virtuous cycle instead of the vicious cycle that we have. And think about how this could work. Now let's see if I can do this light without hurting anybody. I guess you could sort of see it there. So if we use the science, if we use research to design our interventions, and to design, I was talking earlier when we had the chat, I was talking about designing a system or a strategy, a whole strategic system of prevention or treatment interventions. And then we implemented that and piloted things to test out whether they were going to work in our setting or our community, and then collected data. So I've talked to a lot of people today that do evaluation. How many of you here do evaluation? Oh, good. So you didn't all just go to dinner. Good. So to evaluate whether it's working or not, and then adjust what you're doing to improve the plan that you've designed that you have in your system. And what would be beautiful is if when we learn something, oops, no, it's the wrong buttons. It's going wild. What would be beautiful is if when we learn something, we could share that with others. And when others learn something, they could share that with us. And so for me, this would be the ideal system, the ideal way that we would address substance use issues, not just substance use disorders, but all of the issues for substance abuse in the world. So I am a dreamer, I'm an idealist. I like to take really big, hard problems and try to solve them. And so you might be thinking, oh, Kim, that is a lovely dream. But really, how would one do that? How could you even go about starting to shift from where we are with this sort of vicious cycle into that virtuous cycle? And so I think it only takes 4 steps. I think we could start with these 4 steps. And so this is what I've been doing for just since May, actually just for the past few months, is trying to think about how do we move the system in the whole world from where it is now to this way of doing things that will lead to better outcomes and to us continuing to try to do things better. And I think the first step is to figure out who is the workforce. So who's going to do all this work? Because it won't be me. I'm getting ready to retire. I have a few years left. Who's going to do all this work? So we have to figure out who that is. Now it's interesting. I don't know enough about Brazil, so I don't know if you have. I have talked with a few people today, but I don't really know if you have this idea of a prevention specialist or a prevention professional. Is that a concept here? Do people call themselves that? No, I have no's, and I have mostly no's, so I'm going to go with no. Actually, in most countries, it's not really a concept yet. But I think it should be that we can think about. I mean, we talk about treatment professionals, right? If we say, I mean, probably some of you work in treatment and you think of yourself as a treatment professional. You got some kind of education and maybe a certification or something, and you're a professional. And I think we can. The knowledge, skills, and attitudes that are necessary to do science-based prevention are not that different from the knowledge, skills, and attitudes that are necessary to do treatment. Remember, for me, treatment is part of prevention. So we have to identify the workforce. Now, we could just create a new workforce, and I think that's part of what we need to do. But we also have people that are doing this work that wouldn't call themselves a prevention specialist or a professional, but they're already doing it. They're working in schools, they're working in communities, they might be working in law enforcement or in healthcare. And so the first step is just to figure out who are all these people that might be doing this work already, or who are these students in programs and schools that might be interested in having this knowledge so they could do the work when they graduate. And then giving them that information, training or education, and then making sure they know what they're talking about by having them pass some kind of a test, credentialing, and then having that ongoing education because the science changes, we forget things. I mean, we have to, and technology evolves, and so we really have to keep learning all our whole lives. So I think those are the 4 steps to get to that perfect world. What do you think? Do you think it's going to be that easy? Well, some other people have already, before I got involved, some other people have already done parts of those steps. So some people here are doing these, a course on the Universal Prevention course. And I've seen some of you here, people that are doing that course. Yes, thank you for coming. I know you've been working hard all day. I really appreciate it. So there are actually courses to teach people this information about what the science says about prevention and treatment. And they have been, they were originally written in English with a somewhat American bias. And they have been translated and adapted, and people are working now on making sure that they are culturally appropriate for different countries. And that was actually a conversation I had at lunch a little bit, was what would we need to do to change these to be best suited for folks in Brazil. So this is, I think somebody else at another point might go into detail about these courses, so I'm just going to cover, you can see that they cover a lot of material. And there's, and this is the prevention one, because I didn't do this, so everything isn't prevention, it's prevention and treatment, it's that first model. And you can see that it's got a lot of material, and there's a lot of courses, and the people that are taking the courses today are taking are doing 3 days or 5 days of training, and they're doing just some of these specific ones on the bottom. So there's quite a lot of information, and then there's the treatment one. So the coursework, the curricula, the information exists already to be able to do this training. And there's a system designed actually where we have global trainers, and some of those people are here in Brazil this week, and they are training people that we hope become either national trainers or people that work in universities that will teach courses. And then those people will do training here in Brazil in the different states. So this is next year. Brazil will be one of the colored spots on the map. You can see all the places last year that people have gotten the same training, the science-based training. So okay, that's the first 2 boxes. The second box is credentialing, so how do we know that you actually learned something in your course? And so there is a process, there actually is a way to get an international prevention specialist credential. So if you're interested in that, you can, I think Becky Vaughn did some talks, if you're interested in it afterwards, I can try to get your information and connect you with her. But there is actually a way that you can be certified as a prevention specialist with an international certificate. And then there's ISIP. Now, do you all know ISIP? Yes? Right, hands? Yeah. Because at this conference, we're launching the Brazil. What's the word? The Brazil affiliate of ISIP. So this is a way of making sure that people are connected with each other in terms of who, people that work in the same field can be connected with each other and be part of an international association. So I know some of you, and I have myself been involved in national associations or local associations, and I'm fascinated by this idea of an international association where you can, the great thing about the internet now is you can type something in your own language and it will translate it. And sometimes it's kind of funny how it translates, but often enough, it makes enough sense that you can understand, and so you can have dialogues with people all over the world and say, this is this thing that we're struggling with, and how did you solve that problem? And people can answer from all over the world. And so that's the idea of ISIP, is this organization of prevention and treatment specialists, professionals, who are part of an international association and can help each other. And so I took a picture last night of all, the big crowd that was here last night. I took a picture of that, so the next time I do this presentation somewhere, I'm going to have your pictures on it. Is that okay? Yeah? Okay, good. And the other thing, community coalitions. No, we wouldn't call people that are involved in community coalitions necessarily professionals, right? But they do so much of the work of prevention that I think we can't leave them out. So do you know CADCA? People know CADCA? CADCA is the International Association for people that are involved in community coalitions. And so they have been doing their work for many years. A long time ago, I was on the board of directors of CADCA. So we have this concept, this idea of this virtuous cycle where we're doing prevention that works, and we're improving our processes all the time in terms of how we do prevention, and we're making sure that people all around our own country and all around the world know what we're doing that's working, and we're learning what other people are doing that's working. And we have these organizations that are helping all of the professionals and the community members that are doing all this work. But the universities, many universities were involved in creating those courses, and they sort of felt like left out a little bit, that we had created these associations in this way of having all of those people work together all across the world. And the universities felt like we had all these things that they couldn't solve. Now, I apologize that I have these slides with just words on them, and they're words in English. How many of you, does anyone speak English? How many speak English? Yes, so everybody else, I'm so sorry. That my slide, I tried to get rid of words, but you'll just have to look at me and listen to me. So they had these questions, how do we create a course that people will actually come to? So if in our country we don't have prevention specialists or prevention professionals, if we create a course at our university, who's going to come? Why would anyone come to that? And how do we convince our administration, our university administration, to actually allow us to host a course? Because there's so much now around workforce development and making sure that the university is training the workforce. And so And so they really were struggling with, we know this is important material. We know people in many fields need to have this information, but we don't know really how to get started. And so in March of 2016, there was a meeting. I might have a picture of the meeting. Let me see. There we go. In March of 2016, a group of universities came together in Honolulu, Hawaii, in the United States. Now, I wasn't at that meeting. I so wish I was. Honolulu is a beautiful place. And this is the group of people that came, and they decided that they needed a group too. They needed an association of universities. And so they came up with this horrible name, the International Consortium of Universities for Drug Demand Reduction, ICUDDR, that nobody can remember because it doesn't sound like anything. But it does say what it is. It's the International Consortium of Universities for Drug Demand Reduction. Is drug demand reduction, do you use that word in Brazil for prevention and treatment? You do use those words, because not everybody does, and in the United States we don't use those words very much. This is another language thing, and I was really confused. I wanted to get rid of those words, but then as I started traveling around the world, I learned, oh no, I'm the only one that doesn't use those words. Those are very common words. So anyway, this is this organization that just was begun. Let me make sure I don't take over my time. So just quickly, since these are, I'm going to read because these are just English words that aren't very useful to you. There are 5 goals for ICDDR. The first one is network development. So we are trying to create an international network of universities that teach drug demand reduction. So I know some of you probably thought that my talk tonight was going to be on prevention of substance use in the universities. And I'm sorry that if I'm disappointing you, I hope it's not the majority. Because what I'm talking about is teaching and training people in doing prevention, which is a different thing, I know. So we wanted to create this network, and if you work for a university and you either are teaching about drug demand reduction, alcohol, tobacco and drug, we would love to have you join. Or if you're interested in teaching a course or a program. And we want to educate students. We really want to make sure that there are programs everywhere in the world so that people can learn the science of prevention. We want to do applied research and internationally. So there's a lot of research that comes out of the United States and out of Europe and out of really English-speaking countries that, and there's not as much, the publications that come out of the non-English-speaking countries don't get as widely read or cited. So the research that you do here might not be as well known across the globe. And so one of the things that we want to do is do research with people across countries, but also make sure that the research that is done and is published in journals that aren't English, that gets disseminated as well. And to do outreach with the communities. One of the goals is to make sure that the students in the courses have a place to work. And so working with communities and to do community placements with schools, and to create that workforce and the place for people to work. And advocacy, you can see, advocacy takes its whole page by itself. That's the thing that people thought was the most important, to actually advocate with governments, with universities, with communities, to make sure that, that there is education for people that want to work in this field. So this is the website, icuddr.com. I won't belabor it. It's still a work in progress. You'll go to some pages and it will stay under construction. We're still a new organization, although we're a new organization that has 128 members after only 5 months. And they're from 40 countries. In Latin America and Caribbean, we have 31 members from 13 countries, but not Brazil. So I'm hoping that maybe tomorrow or the next day, we will have some members from Brazil. So what we're doing is, I'm not going to go through all of these because it's a little bit boring, but what we're really trying to do this year is build up the membership, get more people involved, get more people sharing with each other, more active engagement across the universities, and to create student exchange. I think one of the things that will help us develop programs that are more culturally relevant is if people have the opportunity to do work outside their own culture and to do student exchange across countries. And then you kind of get a better sense of what is just, this is just the way we do it in our country, and other countries are different, and what kinds of things are actually universal that everybody in the world does. And we're working to create regional coordinating centers because there is something about being able to communicate in your own language and have meetings in a time zone that makes sense. And so we will be doing work regionally, and we're in a conversation with OAS, with CCAD, to be the regional coordinator for this. Okay. So that's how I think we're going to get to this perfect world, where we are sharing, not just within our own country or our own community or even within our own university, but all across the world, and trying to improve the services that we do all across the world, and sharing what works and what doesn't work between countries and between people that work in the field. And I think, I'm going to read something because it's late and I'm not that articulate anymore. I think that we live in a time when there's much conflict. It's my experience within our countries and between countries right now. And I'm hoping that the creation of ICDDR, along with ISEP, along with CADCA, is a way of providing opportunities for academics and people that interact with academics, with communities, to provide agreement in a world that's full of disagreement. So we can agree that alcohol, tobacco, and drug use is a complex human behavior that's driven by environmental, social, psychological, and biological factors that all interact to increase or decrease the probability of use and the problems that are related to use. We can agree that it is critical that people working in health and social welfare professions understand the basic science of substance use and addiction. And we can agree that improving our understanding of the problems and solutions of substance use and addiction through research and education are critical roles of universities all over the world. Do you agree with that? Okay. I didn't want to speak for you. And so, I think that ICDDR can provide an opportunity for us to share our learning, our experience, and our struggles to achieve this vision of a world where addiction and other consequences of substance use are rare, where people with substance use disorders have access to quality care that can treat their health conditions, and where the quality of life for people with substance use disorders and their families is improved through evidence-based medicine and social welfare programs. I think this is a worthy goal. It's a worthy goal for us to join together to improve our own programs of research and study, and to help other universities and the communities that they work in to develop alcohol and drug study programs. Our leaders may and will bicker over many things, but we have the opportunity to come together to address this critical problem and improve the quality of life across the globe. So I want to thank you for being here this evening and listening to me talk. And I hope you will join